Hi, everyone. This is Jason Harris. I'm the founder of Jason's Connection, and I'm so happy to be able to do this with Mai and Yolanda. This is something that when we started Jason's Connection, we did a little bit of podcasting, but it was a lot. But this is so exciting to be able to collaborate, to be able to talk about something that affects so many people in our community and seeing good work that is being done and how to be able to be involved. So I'm excited to be able to have this conversation with Mai and Yolanda about IEC. And so we can get right into it. So Mai, what is IEC, or the Institute for Exceptional Care? And tell us, what is it about and its mission and some core focuses? Sorry, I know that's like three things at once.
That's okay. I'm as excited as you are, Jason, to be here tonight. So thank you so much for having us. And this is my introduction to the Jason's Connection community. So we're just thrilled. So Institute for Exceptional Care, or IEC, is a nonprofit. We're pretty young. We're only 3 years old. Totally focused on improving healthcare for people with intellectual and/or developmental disabilities. That's all we do. But within healthcare, we focus on three core areas: changing how healthcare is taught, how it's delivered, and how it's paid for. Because we know from our own healthcare backgrounds, and with many of us having the lived experience of either having IDD or supporting loved ones with IDD, that those three areas of healthcare are broken right now, and that you can only improve them if you improve them all at the same time. So that's IEC in a nutshell.
Thank you so much. So, before we get into a little bit more about what IEC is and what it's doing, Yolanda and Mike, can you tell us a little bit about yourselves and your experiences and background, what you do professionally, and then how you got involved with IEC?
Sure. Yolanda, do you want to start or do you want me to?
Yeah, I can. I'll start with the first question or the last question first. So I
Yeah.
get involved with IEC through their Ideal program, where I was actually a participant sharing my experiences with the healthcare system. And then from there, I learned more about their mission and joined their board, as well as a group of self advocates that they were bringing up to kind of foster the creation of a larger group of self advocate volunteers and bring up a volunteer core. My background initially was kind of in the disability nonprofit world, working at an independent living center here in California, overseeing their youth program. It's kind of shifted more into just overall youth support, as well as like changing healthcare for the better for people with IDD. I also work with the WITH Foundation as part of their advisory board. WITH stands for Working for Inclusive Transformative Healthcare. So that's why we call it WITH. It's a little bit shorter. But besides that, I'm currently just a student and the eighth of 9 children. So that's always a fun
Wow.
fact about me. But that's pretty much it.
Oh, just that's all.
Yeah. Got
almost
it.
an
Just
almost
all
straight A
the things.
student. The mirror of that for me is that I didn't start with the disability expertise that Yolanda has. I came from inside healthcare. So I'm a physician. I'm a general internist by background. And when I was seeing patients, I mostly saw patients in underserved communities and in free clinics. And then I have done research in health policy. And then I went into government, and I was actually working for Medicare and Medicaid for about 6 years after the Affordable Care Act passed. And I was helping to run giant payment and healthcare delivery experiments in Medicare and Medicaid. And I've also done some private insurance work for one of the largest insurance companies in the country. But I think the other really important background piece about me is that I'm a mom, and I have two kids. I can't call them kids; they're 24 and 21. But my second born, Alexander, is autistic, and he has taught both of his parents a lot about disability and parenting. And it was coming out of finding our way out of his first mental health crisis in high school that led me to ask a lot of questions about how we failed him, how the system failed us, and realizing that, wow, I was super oblivious to how families with disabilities live, and that may be actually pretty typical of general healthcare leaders. I was not an outlier in that regard. And so all that curiosity is what led to the decision to start IEC.
Yeah, I really appreciate that. And I want to be, I'm not going to describe myself. I know there's ways to see it on Jason's connection, sort of my background and information, but because I'm really big on transparency and stuff, I want to talk over really quick about how Mai and I sort of got together, and it was through a mutual friend. He knew about Jason's connection and some of the things that Mai is doing around technology that we we'll probably get touched on a little bit later. And we met in Cincinnati, where I'm from, and it was just sort of blossomed from there of, her asking me to do stuff with her and seeing what they're doing, because it's such a cool thing. And so, not to belabor it, but just making, I think it's important to know that there's a working relationship here as well. And, as we brought this together, thank you. So you'll be going into this, and that there is so much, and there's bigger systems. Yolanda, what are some of the challenges of navigating the healthcare system and finding resources?
Yeah, it's such a scary thing when you start out. So I was born with cerebral palsy in California. So I was really lucky to have pretty good healthcare coverage. And kind of growing up, I always knew who my doctors were, and that I would mostly go to like an orthopedist, and we do these scans every year. So I thought I understood. Really easy to be like kind of a backseat healthcare person when your mom and your dad are taking care of most of your healthcare. But some things happened in my family where I ended up having to step up at a really young age and take control of my healthcare. Hopefully, most of the people watching that are younger people or parents of loved ones with disabilities, just a little warning, like start prepping people as soon as possible, because it is such an undertaking. But basically, I got thrown into the healthcare world, and I didn't know that you could change your doctor. I didn't know that there were options. I didn't know that you could find more information about your doctors using online resources to find somebody that really understands your condition, especially as you get older. I think with cerebral palsy, like many intellectual and developmental disabilities, the focus is on supporting children, which is important. Obviously, we want to support children, but the whole goal of this is for those children to become adults, and how do we continue to support them? And I think that's one of the major kind of barriers to better healthcare that you might find as you transition out of child-based care and looking for something that'll meet your needs as an adult. And then also just advocating for yourself. I think a lot of people aren't used to being told by a person that's disabled what their needs are directly. And so that can be a culture shock for them. So be ready to potentially deal with ignorance and a bit of pushback. But again, that's something that IEC is really looking to change, is that we're connecting with medical students before they even become doctors, to make sure that it's not so scary when somebody with a disability is communicating with you directly and openly and honestly. So that's just kind of a snapshot of what that's like. Hopefully it's not like that for everyone in the future.
Yeah, I mean, just a little bit of a follow up on that because I think it's so interesting within like the medical field, like medicine. It seems like, and I could be overgeneralizing it. Ma, you can also chime in after with Yolanda. We tends to focus on sort of acute sort of things and sort of like overcoming things, and disability, especially as a long term thing, comes into sort of the sort of bigger sort of outside the medical office, or just not just about the disability itself. And it seems like that's a bigger issue in medicine itself, is how do you take the whole person into account? Like, is there things that you recommend as somebody who's going into the office of how to educate, or things that you're going through as you're trying to educate as doctors or insurance agencies, as well as people with disabilities, of how to advocate for their rights?
Are you asking me, Jason, or Yolanda?
I was more asking Yolanda, but Ma, you can chime in. Sorry, I was not clear.
Yeah, no, go ahead, Yolanda.
Okay. Well, I've had more of the customer service kind of front facing business. I have had some opportunities to talk to insurance professionals through IEC because they create such a direct pipeline to people that are influential in insurance. But prior to that, I hadn't really. So most of my experience with educating people is kind of building rapport with, my general physician, or maybe the office that they work at, or my wheelchair vendor, where it's like, okay, we're starting from ground zero. Let me just casually drop that I'm invested in my community and I do all of this nonprofit work. And maybe if I have a job, like as horrible as that sounds, I do think that, telling your medical professionals about yourself and the things that you do, and that those things are important, kind of makes them realize, like, oh, I have these preconceived notions. Maybe I need to check myself before, just making assumptions about this person and what they might need. I mainly do it to show them that I am competent in handling my own care, just because I want them to feel secure in, like, this person knows what they need. Let me just listen to them. Sometimes that helps, sometimes it doesn't. I try to really read the room and see if they need like a gentle hand with it, where like we can just kind of joke if they maybe speak over me a little bit, or if they refer, to the person who's, maybe dropping me off and is a Lyft driver and not anyone related to my healthcare team, or support team. So it really just depends, how you think they'll respond to it, especially if it's, I kind of, if it's a one-off doctor you're probably never going to see again, and it was a negative experience, feel free to just be direct and honest with them, and maybe even a little bit blunt. But if it's somebody that you're going to have to work with for a bit of time, then, invest in that relationship just like you would with like a classmate or a friend or acquaintance, where you're going to be seeing them a lot. Maybe try not to burn those bridges. But again, each their own.
Yeah. And I guess I would say, Jason, that IEC kind of takes that posture and we try to scale it. So what I mean by that is Yolanda touched on several themes, right? One was humanizing the person with disability to the healthcare team. Well, we do that all the time, just because in every project, we work through coalitions. We work by bringing together actual community members. We love our disability organization partners, but it's the individual community members who are most central to our work. We bring them into the same room as healthcare decision makers. I mean, big shot insurance executives and government leaders and hospital CEOs. But we do a lot of work to support community members with everything from plain language translation to graphic facilitation to prep calls or pre-meeting videos, whatever they need, both before the meetings and in the meeting, to contribute as fully as possible. And then we role model for our healthcare colleagues, this is how you make space, this is how you share power, And look at that. When you bother to make space and share power, it turns out you don't have to have all of the answers to everything all of the time, healthcare professional, because the community members are telling you what the answers are. And suddenly you get to the right answer much faster. And I think the other thing that Yolanda touched on was, you know, this notion of assuming good intent. IEC doesn't come to this work blaming individuals in healthcare. We want to assume good intent among individuals in healthcare. We think the system sucks. We think the system has let down the professionals and doesn't support the professionals, hasn't given them enough training, doesn't give them the tools, you know, doesn't support them with the right policies. And so that's what we want to change, is the system around them. And so oftentimes we find that the best way to get healthcare leaders super invested in the change making we want to do is we present it to them as, we think you have a problem. We think you, ER doc, have a real problem when someone with IDD comes into your setting and your team isn't trained and you don't have the right tools and you don't know what to do, and the patients are stressed out and you're stressed out, and then bad decisions get made. Here's a way we can help you with that. Hey, we've got an app, you know, that your patients can use where they can tell you things like, here are some tips on how to work with me, or here are my anxiety triggers, and here are ways to calm me down. Wouldn't that make your life easier? And they nod. And then you say, would you like to learn how to use it? And suddenly they're inviting the learning, you know? And then everyone's problems are being solved at the same time.
Yeah, that's so important, that it is, you know, not saying, oh, well, individuals are bad, whether it's the people with disabilities themselves or the practitioners, but it is a system-wide thing. And I know you touched on it a little bit, but what are some of the projects that IEC is working on right now?
Yeah, so Yolanda mentioned one of them that she's actually heavily involved in. It's something we call the IDD Advocate Corps, and it's a new project. We're just standing it up now after like a year's worth of design work with 20 founding advisors, and they were almost equal numbers of IDD self-advocates and family members and healthcare professionals. And what it is a new advocacy network. We're saying we're going to bring together these passionate volunteer healthcare leaders. They have day jobs, but they're also really committed to this mission. And they want to make change in their organizations, in their communities. Well, but they can't do that without the partnership of community members who bring the lived experience, right? Who bring that wisdom, who bring that face of what the issues really are, and who can articulate in their own communities in much more compelling ways. So we put them together. We're going to give them training in advocacy and help them develop tools like fact sheets and videos and talking points. And then they're going to pick, you know, the priority problems they want to work on. That could be training medical students. That could be getting emergency rooms to change how they're set up in order to serve our community better. But whatever it is, they will pick their focus and they will zero in on that, and they will start advocating on the ground. So that's one project. Jason, I want to give you a shout out for the project you're most involved in, which is something we call Making IDD Visible. And that's really to address this problem that in healthcare data, most people with IDD are not recorded as such. That means that when you show up to, you know, get an X-ray, or you show up to an oncologist, or if you have to go to urgent care, the people who are trying to serve you don't know about your underlying IDD, and that may lead to wrong decisions. It also leads to insurance companies thinking, oh, this population is too small for me to think about. Right? When in fact it's not. It's almost the size of the diabetic population. And so our job in making IDD visible is to find a way, we're building a data tool to automate the identification of people who may have undocumented IDD. And you don't stop with the tool. The tool is just something to start the conversation with, but it helps that clinician, it helps that community clinic, it helps that Medicaid health plan to figure out, okay, here are the people I need to have conversations with. I need to find out, do they know if they have IDD? If they don't know, but they're curious, can we help get them diagnosed or assessed? And then how do we use that information to support them in their well-being? So those are a couple of examples. And I did mention that digital app. I do want to call that one out to Jason, because that one is getting ready to go live on Long Island in New York. It's called Always Uniquely Me.
Yeah, and that's how we met too. Is through the
exactly.
app. Yeah. Sorry, I cut you.
No.
You can cut you off from talking more about the app if you want to. Sorry.
No. I already described it. It's just to let folks know that we think this is a tool. This tool is one of those examples of how the genius of people with IDD can lead us to better healthcare for everyone. Because to be honest, that app, when it's ready to really scale, will be so great for my 84-year-old Vietnamese speaking hard of hearing mother, who has very similar needs. She has communication challenges. She has sensory challenges. She, has language challenges. A lot of people can use a tool like this, but it took the bravery of people with IDD sharing what their needs are, sharing their perspectives on how they think the problem can be solved to get us to this solution.
Yeah. No, thank you. And Yolanda, I know you touched on it a little bit of what taking control of your own healthcare looks like. Can you talk about, I think too with the IDD Advocate Corps, how does that, and I know you touched on it a little bit too, how does that help to have people who have some similar lived experiences? Obviously not everybody has the exact same, but being able to come together and work together in a non-hierarchical space, but then be able to advise others as well on sort of taking control of your own healthcare or different things that people have gone through. What has that been like for you?
I think it's been really amazing because when you're disabled, I think you're constantly looking for community. You're constantly looking for being able to just have a moment to relax, to not always have to explain yourself and make space for yourself. Like you can just exist. And when you tell people, about your positive or negative experiences, and they've shared some of those experiences, and they understand why that particular thing might be a triumph or a hardship, it just makes life so much easier. I think one of the biggest things that we all talked about kind of early on in the beginning, I think it just kind of came up naturally, is how difficult it can be to manage your mental health while kind of navigating the healthcare system in general, and how that can be so draining and dehumanizing and lonely. Like, even though you could be professionally on it, you could be killing it in school, it still feels like when you're begging for something that you need just to exist, that society doesn't care about you, that you're going to exist on the margins forever, and that's the way society wants it. But then you talk to people that are actively doing work to change that, that have such a strong sense of hope and passion, and they also see it too, where it's like, it's not things that we're doing wrong as individuals, it's just the structure of a system that no longer works for anyone. Both doctors and their patients are feeling this pressure that we've created, um, to maybe save a few bucks here or there for a few people. It's harming so many others. and just being able to say that and not being seen as negative, and then also immediately be like, okay, you've let out your feelings and you've kind of put out ideas. How can we make those feelings and ideas like tangible change in the world? And I think that's one of our greatest strengths that I really enjoy, because sometimes you tell people things and they don't have a base like shared experience of like having that disability, and they're like, wow, people are like that, or it's really like that for you. It's like, no, nobody's surprised when about a hardship or social isolation or just being so happy to be in a group that gets it. Especially for those of us that are like multiply marginalized, like Mexican and being queer, and also having a space where we can talk about disability and those other parts of my identity. And nobody's like, okay, well, we can't talk about that because that's not the mission. It's like, no, IEC sees the whole mission, and that those communities are part of the fight for better healthcare as well. So it's not like, okay, we'll get our cookie and then everybody else can get their cookie after. We're all getting cookies together, which is kind of why I love IEC. Like nobody's left behind.
Yeah. Oh, go ahead.
I was going to say, Jason, it's not just that we don't want to leave anybody behind, but, to be honest, we used to get a little anxious when our self-advocates would scold us, like if they thought we used wrong language or we did something wrong or we were insensitive about something. I'd get really stressed out. And now, like, I still receive it as like oh, oops, we got to fix something. But I also do a little happy dance because I remind myself, we just learned something. That means we're going to get better. And I think that's hopefully, I think hopefully that's part of what Yolanda means. It's like, we're all in it together.
Yes.
And everybody has learned something. Yeah.
Well, and I think, like, I know for myself as doing some of the stuff I do, if I'm telling you some of this stuff, I mean, and I know different people have different reasons, it's also because I care and I feel like I trust you enough that we might not necessarily always agree on stuff, but we'll listen to each other.
Yeah. And we, when people make comments in our working meetings, sometimes to some people it may sound like it's off topic. It never does to us. There's always some space, some way that you can find value in what a community member is saying. And so that we work really hard at that.
Yeah. I see a question from Gretchen in the chat, which I think is really interesting and sort of goes with it. What do you see as the biggest block doctors and other clinicians have when working with you or other people with IDD? I know, or if you have family members, and people can also share in the comments who are watching live. We'd love to hear from you as well if you have things that you want to share.
I guess I can go first. I think one of the biggest blocks for me is that, like, oftentimes my doctors don't have time. Like, not enough time in their window to see me, where I think they unfortunately might have to cut corners to make it work. Like, for example, I need a, wheelchair weighing apparatus to properly get my actual weight, but a lot of doctors' offices will just be like, give me a guesstimate. And I'm like, well, if you're prescribing medication, maybe let's get out that wheelchair, scale. Let's do the whole thing. But it's just, for some, they just don't have the time to. And then just learning how to be uncomfortable can be really hard for anybody.
Yeah.
I think that's part of it as well, is where they're not allowed to be uncomfortable
Right.
in a lot of their trainings, and wanting to maintain professionalism and thinking that professionalism means having all the answers, which it doesn't. And it's just helping people unlearn that is kind of the biggest block that I faced.
Yeah, I agree with you on both counts, Yolanda. we part of our work is championing new ways, new policies for how providers, healthcare providers get paid. It's about how much they get paid, what they get paid for, and how they get paid. Is it in a lump sum, or is it like drip, 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 and you have to bill for each little thing? Because if you have to bill for each little thing, you're kind of trying to carve a person up into the tiny little individual things that they might need instead of looking at the whole person and their goals. So we really like to champion healthcare groups that are getting it right or trying to get it right. Like one of the largest dental insurance companies in the country, Delta Dental, has some new benefits that they're covering, where they're covering more frequent teeth cleanings. They're paying for longer visits for people with special needs because they know that that's what you need to get someone comfortable in a stressful setting. And it's small things like this. It's acknowledging that, gee, someone might need to visit 6 different dentists before they find the right one, because most of them aren't going to be a good match. It's little things like that like a smart healthcare organization realizes in the long term, that's going to generate value for them. It's going to make their customers happier. It's going to keep their customers safer. And it'll save them a lot of grief over things like unnecessary anesthesia or unnecessary hospitalizations.
Yeah, I mean, and I think it's important because, I mean, I know we've covered it a little bit on Jason's connection at some point, but like dental isn't really covered under Medicaid, and you really, if you're lucky, only get one a year, and that doesn't take a lot of flexibility. But I also hear a lot of what you're saying in some ways as a sort of universal design sort of prospect as well, of like things. Some of this is just about good, like patient care and holistic sort of things that is important to specifically think about with people with disabilities who are underserved, but also go into bigger movements of health equity and other movements around with different groups as well, marginalized, and just in general of how to make healthcare more accessible and not feel like you're just coming in and you're a check on a box, or some of the problems with the insurance industry that people are putting up. Some of these things are also bigger systemic issues as well. Now, obviously focusing more on a population that doesn't, and a group of people like myself and others who don't always get underserved and less care, it's really important.
Yeah, I'm curious, Yolanda, because you kind of, are active in so many different communities. I'm curious what your perspective is on what are the adjacent communities to IDD that you think are natural allies, in this kind of work.
I think queer spaces and trans spaces are doing a lot of great work on reproductive justice and preventative care, and showing them that people that need certain types of preventative cares like pap smears and other kinds of screenings for various cancers and preventable diseases exist on a spectrum. And so when we talk about these kinds of healthcare, we need to not only watch the language that we use, but understand that we could benefit so many more people just by being slightly more open-minded. And again, I think they could be really great allies because there's so much overlap between disability and queerness for so many reasons. And not to stigmatize or pathologize queerness or transness, but it's just when you experience so much trauma, it creates disability, but also so many people that are on the gender spectrum beyond, cis identities also identify as neurodivergent. And we need to embrace all of our siblings.
Oh yeah, I mean
Yeah.
it's so important. That's one of the. I mean, I know I'm one of those people who's neurodivergent and and don't necessarily go into heteronormity or cis. That's why I put he, they, and then I put it as a little bit of a play on it. But I think it's also interesting, like because I'm a little bit sardonic and stuff. But then also even sexuality wise, like the idea of like who you're interested in. There's such a broad spectrum of things, and I think there's a lot of reasons that neurodivergent people, and not just pathology wise, there's also like social constructs and stuff go into that, and there's so many other communities. And I know I didn't, sorry if I cut you off. I know, Reen, it's interesting because I've also had my own experiences with that. It's one of those interesting things too, where like one of the things for like the odd diagnosis of autism is like gender like dysphoria, which is also used for like other sort of like LGBT, like having to get like surgeries or like affirming care in some ways. I know that like sometimes as an autistic person, they see like the diagnosis and like more than they see me as a person, or even sometimes like with the dentist, like I have a lot of sensory issues around brushing, and they're like, brushing is this simple. You just put your hand like that, and that's how easy it is, which is like, that's not my problem with brushing, but I think it goes back into like, how do we make this person centered, and realizing that people are, one of my favorite terms with Kimberly Crenshaw, intersectionality, that we're a bunch of different identities. Sorry if I didn't want to cut you off, but.
No, first of all, I'm learning all kinds of things about you that are just, I think, amazing. No, I was just going to riff on what you both said because, in one of our projects, when the one that Yolanda first participated in, the one called Ideal, which is really about figuring out what are the health priorities in the IDD community and how can healthcare best support those priorities. And one of those key domains was around sexual, reproductive, gender, health, and parenting.
Yeah.
For the simple kind of basic human need that people with IDD want to be recognized as whole human beings who want to have a sexual life or who want to understand the options, and their own gender identity, and the mountain of kind of I don't know, just kind of obliviousness that they have to climb with healthcare professionals who just make false assumptions about, well, if you have all these problems, I don't think you're going to be thinking about having a sexual life. It's like, well, that's kind of not up to you to decide. And it's your job to help me think that through. It's your job to help me navigate that and to offer me my options. So I just wanted to call out that theme that, it is about intersectional identities. It is about whole personness and seeing that in healthcare. It's also just about like recognizing basic human needs.
Yeah. Well, that reminds me of I know there's been recent studies with the quality of life and the perception of doctors of quality of life for people with disabilities, and then people with disabilities, rate that they have higher quality of life than the doctors would assume that the people with disabilities have, which is in its own sense it's troubling just because of the way the treatment happens and then the way the care gets rationed and stuff, especially during a pandemic. Those things have big impacts. And I don't know, Yolanda, if you have thoughts on that, or or just because those go into some of the work, or we can move. Yeah.
Well, Yolanda, I bet you have some California specific experiences for sure. But
I mean, it makes me sad. It makes me sad. But that's confirmed like via research. I think a lot of disabled people will tell you that they could have said that without research, but it's good to, not good, but like it confirms a lot of suspicions that I've had in situations. And again, that's why I always feel the need to improve my quality of life
Yeah.
in some weird way. Like whether it's like, look at this adorable cat that I have. See, I have things that I love.
Yeah.
Please take care of me. And we shouldn't have to do that.
Right. And you can't do that if you're in extremis, right?
Exactly.
So in the early months of the pandemic, when people with IDD showed up at hospitals, they were systematically more likely to be denied ventilator support and ICU beds because clinicians were making assumptions about
Yeah.
quality of life or even life expectancy, which is now over 70 years old.
Yeah.
And it took like a 50-state advocacy effort to make sure that that kind of rationing did not keep happening. But people died. A lot of people died while it was still happening. And throughout the pandemic, having intellectual disability was the single strongest predictor of death from COVID other than age.
Yeah.
Just stop and think about that for a second.
Oh my God. Well, and we still see that with organ transplants. Sorry, Yolanda, I cut you off.
Oh, no worries. I was just going to say, yeah, it's always awkward to have to explain to someone whenever I'm having an issue related to my disability that, unfortunately, healthcare teams and healthcare professionals and healthcare organizations kind of aren't my first go-to place to which they should be. You would think that you would have a level of understanding and support in these spaces. But again, in actuality, navigating them can be a inadvertently violent place when you're facing potential death because you can't advocate for yourself to get the care that somebody who doesn't have your condition would get. So I think that's probably heartbreaking for people to hear, and then also for loved ones to hear, because I know that, especially during the pandemic, a lot of people were separated from their loved ones once they entered the hospital. And, maybe things would have been differently if they could have had, familial support or just their support system in general. But now that we're understanding that might not always be available to somebody, not even for them lacking that, but just because there might be situations again in the future, knock on wood, hopefully that doesn't happen. But, it just shows that the way that things currently exist are really the things that we're doing to like mitigate the damage of the systems are only band-aids. And we need something that truly changes things systemically and provides training and cultural competency for more medical professionals.
Well, and that goes in really great with, I see what Jeff Harris put in the chat. And one of the questions that I sort of had, IEC has been very intentional on involving people with disabilities, insurance company, physicians, and family members. Sort of how have you been intentional and how are you building a relationship between those different groups? Because sometimes it can seem like it's just conflict, but a lot of times there's things that they want that are common too. So how has that sort of worked so far?
Yeah, no, thanks for that question, Jason. Let me try to unpack it a little bit. So, let's say there's a problem that we all want to solve, and we bring together these different stakeholders. Some of it is kind of establishing group norms, right? We kind of lay out ground rules that everyone agrees to about being respectful, about slowing down, about not emphasizing our professional titles or degrees, but instead sharing something human. Like we have this sheep scale of emotions, 9 different sheep exhibiting different emotions. And we ask everyone, what sheep are you today? It has nothing to do with what you did in school or how many degrees you have. What it does do is give you a little window, a little line of sight into how that person is doing that day. And it humanizes not just people with IDD, but also that super stressed out insurance executive, and why they're close to tears. And And so we set norms for the group like that. We also, show the healthcare leaders all of the wholeness of community members. So we celebrate good things that happen in their lives. We allow them to share, if they want, the bad things that happen in their lives. We let them talk directly to one another so that they can each understand the context that they live in. And when we go to solve problems, we do it very intentionally with multiple rounds of consensus building and review. We have a certain method for making decisions. Like, you can vote. That's one way to make decisions, right? But then the majority wins and everybody else feels bad. Another way to do it is this rubric we have where we say, tell us which one of these is most true for you. You really agree with this decision and you're all for it. Or this is a decision you don't feel great about, but you're willing to live with it if other people want to. Or this is a decision that you really don't have any opinion on and you're okay either way. Or this is a decision that you cannot live with. If anyone picks that last option, we go back and we have another conversation and we try to make compromises until we can get to a consensus that everybody feels comfortable with. And something happens in that process, because you do that process over and over again, because we make lots of decisions together, right? Whether it's designing an app or standing up the IDD Advocate Corps. The process of that happening kind of instills in the healthcare professionals this really deep respect for community members, because they really start to see how much they, the healthcare professionals, are learning from community members. They become totally addicted to the experience, Jason. They ask to come back. We had this crazy experience this year where like 3 or 4 federal agency people, leaders in those federal agencies invited themselves to our meetings because they didn't want to miss it, especially because they knew that community members would be there. Think about it. Their lives are usually, 40 hours a week sitting in an office or working remotely at home somewhere with other people just like them. How often do they get to actually interact with community members? And when they do, they realize, oh, that person has the answer I need. And how come people don't offer me this experience more often? And then what's really magical is when we see like pairs of people bonding throughout the project, and then they go off and have their own little relationships, and we're like, oh, that's interesting. And then they tell their friends and they tell their friends. And so it kind of expands outward like that. And that's how we build community. But yeah. Yolanda, I would love your perspective on
yes,
like whether that feels true to you or.
Oh, definitely. We were able to meet a little bit in person early. I think it was, was it October or November?
I think it was September, end of September.
End of September. I'm sorry. Yeah. I just got done with finals, everybody. So
congratulations.
Together, yes. But yeah, no. So I was able to get to speak to people, and I'm a healthcare major, and I remember speaking to somebody that was also in healthcare communication, and I'm in communication, and I was able to kind of talk to them about what does a job in like healthcare communication focused areas look like. And they were like, yeah, it's so hard for me to, they called themselves a wonk translator. So like all of the very dense and heavy language that healthcare companies use, they kind of translate.
Guilty as charged.
This person would translate it into more accessible language, but even because they've been doing it for so many years, they have to constantly like second guess themselves. Like, is this a phrase that, someone who wasn't me would understand. And I think that's just such a great thing to be able to like pull people out of their little bubbles and mix them with other people. And I think that's probably why IEC is so great to work with, is there's such a big human and relationship component to it.
I know that's one of the reasons I love doing it, is the cross-sectional and the teaming and the, having the different perspectives, but working together from some of the meetings I've been at. So I see a question from Rachel Moore about how family members and friends can help our loved ones navigate their challenges in the healthcare system.
Yeah, it's a great question. And of course, it depends a little bit on how receptive the healthcare providers are that you encounter. But in general, I think that it's always good to lead with transparency and to be right up front, direct about your loved one having IDD and what that means, and giving the healthcare professionals something to cling to remember that this is a real person, right? And that can be anything. That can be a story about them. That can be a picture of them doing something they love to do. And then I think it's about becoming a partner with that healthcare professional or that healthcare team. I can't promise that they will all be willing partners, but I think that you're always better off starting, assuming that good intent, and saying, here, let us share some tips with you about how to work with our loved one. Here's what we've seen works in the past. Here are things that don't work. And here's how we support our loved one. Can you work with us, in a 3-way, 4-way partnership? It takes a little bit of burden off that healthcare provider, because what you don't want to do is to have a healthcare provider feel like they're being cornered. I know my own kind. And I know that when that happens, when they feel underconfident and stressed out, only one of two things happen. Either they shut down or they lash out. That's it. And that's what you want to avoid. You want to always find a way for them to move forward, however small. It may be something super small, like, hey, gee, could you just put a sign up at your registration desk for when, people who have communication challenges come in with like pictures to show them what they're supposed to do instead of long, complicated instructions. Or it could be, gee, we might need 2 visits to get this problem taken care of instead of 1. Would you be less stressed if we schedule 2 visits with you instead of 1? So it's that kind of creative problem solving, which I want to say outright, it's not supposed to be your job, right? That's supposed to be the professional's job. But if we're honest with ourselves, they're not there yet. And we all need to kind of help them along.
Yolanda, I'm curious if you have suggestions for family members of how to support their loved one in some ways, but also not necessarily take over, like how to make it collaborative. Because I know sometimes, as much as I love my parents, and sometimes they can try to fix it for me rather than work with me. And so, like, how can that be doing it with the person you love rather than for them?
Yeah, I definitely think that can be a heavy burden to bear, because I know, so my brother has Down syndrome, and for a while I was kind of overseeing his healthcare needs and helping him with school and things. And I immediately felt the urge of like, oh no, this is my baby. How do I protect my baby? I need him to get the best possible care. How dare anyone deny him? Who do I have to tear through? It's a reasonable and understandable feeling to have. But I think if you really want to help your loved ones and be a part of their healthcare journey, you have to let them take the lead. You need to start having conversations with them about what it looks like to navigate healthcare sooner rather than later, what your part or what they want your part in their healthcare journey to be, where it's like, hey, I love you. what do you need from me? Is it just logistical help where I drive you to your appointments, or, you know, maybe I help you schedule transportation to your appointments? Or do you want me to be in the room with you when you have your appointments? Do you want me to, you know, take notes during your appointments? What can I do to make it easier for you so that every visit with a healthcare professional is as good as it can be? I think that's kind of where you put on your listening ears, and just kind of sit back and let them dictate what they want, but also, you know, give them options. If it's something that they're not used to thinking about, you know, kind of help them plan for the future as well. And I mean, we can all plan for the future better. So it's like, you know, I think that's what parents and other loved ones can do to kind of help people navigate healthcare, is to do as much as you can do before a potential crisis might happen, so that when you're in dire need of help, you already kind of know what your loved one wants, even if they're not, you know, for whatever reason, they might be incapacitated. Because again, we're talking about healthcare, emergencies happen, things happen. Like, you know, I had my gallbladder removed, and because me and my sister had talked so much, she knew exactly how I wanted the doctors to treat me and what care I would be comfortable with. And, you know, if I'm asking for pain medicine, that means, oh, she's really in pain. And she might not have the energy to, you know, be on top of medical professionals, but that means I need to be. And that's a type of trust that only happens from collaboration and communication. So, I mean, I think the best thing you can do is just be as prepared as possible, and giving them tools, like things that they might find on Jason's Connections, where they can look up the kind of healthcare professionals that they might be a better fit with, that are focused on their area, is a great first step.
Yeah. Yeah. And I think asking them how would they like you to help them.
Mm-hmm. Well, thank you. I know we're getting towards where we're going to open it up to Q&A, but I'm really excited. But I have one last question. Well, I have a lot of other questions I want to ask, but at Jason's Connection, we love to be able to share information, but we also hope that by sharing information, that people are able to do things in the way that they want to take action, or being able to, you know, be part of things. So I really want to ask, what are ways that our community members or people in general, whether especially people with disabilities, can be involved with IEC?
Thanks, Jason. So we would so love to have as many of you who would be interested as possible. So you can go to our website, which is www.ie-care.org. And under our work, you will find descriptions of our different projects. So one thing you can do is just contact us through our website and let us know what you might be interested in, and we'll reach back out and have a conversation with you and tell you about upcoming project opportunities, or just get to know you. We love getting to know our partners first one-on-one, and then keeping an eye out for where we think opportunities might arise. The IDD Advocate Corps is another immediate opportunity. We can also put up that link for you in the chat. And right now, what we're doing for IDD Advocate Corps is we're asking people to fill out an interest survey so that we can learn a little bit about, you know, what different problems in healthcare people want to advocate on, how much time you want to devote to this, what kinds of roles you want to play in the IDD Advocate Corps. You know, is that being on a committee? Is that helping with research? Are you a genius at communications like Yolanda is? And so on and so on. So those are a couple of opportunities. And we want to make sure you know that we pay all of our community member participants. This is work. And it's so important to us that we respect that by compensating for your time and your contributions.
Thank you. So I see one question so far, and I hope if other people want to share questions, I can also keep asking. Can you share a success story of when IEC helped someone improve their healthcare in spite of challenges?
Oh, so to be honest, we do a lot of that on an informal basis as well as through our projects. So I guess I would say it's a little indirect, but in one of our projects, we have medical students who themselves have IDD, and they encounter a lot of challenges. I know that's not healthcare per se, but we were able to connect them with mentors, with cognitive behavior therapists to help them think through strategies for taking exams in order to get licensed, and so on and so on. There was another instance of where one of our supporters, their daughter had a terrible experience at a hospital, despite the staff having been told that she needed to take her own COVID test. She's 6 years old, and they did not honor those wishes. She walked out of that hospital encounter with bruises on her body because 3 adults held down this 6-year-old. And the parents were so distraught, and they didn't know where to turn, despite being, having a lot of resources and even having connections to that hospital. So we helped them to connect with the right quality officer to have an honest conversation about how badly that went. And that quality officer really heard them and has gone back and started to rethink the process in their outpatient surgery department about how to prevent that from ever happening again. So those are a few success stories.
Yeah, I'm seeing some interest in learning more about the app and what all does it do.
Yeah. So the app is called Always Uniquely Me. You can see it in Apple and Google Play stores now, but it's still a little glitchy because we're doing some beta testing this month and next month. And then we're going to run a full pilot on Long Island. But basically what it is it has several pages. The first page has kind of like emergency information, right? Things that a first responder team might need to know right away, like your allergies, your age, phone number for your emergency contact, whatever. And then there are different pages behind that they can choose from. It can be clinical information that is not driven by a medical practice or a hospital's electronic record. It is driven by you. You decide what clinical information is most important, because we heard from our community members that they didn't want to be, to have a hospital record say, oh, this is a person with multiple psychiatric hospitalizations, when in fact, from their perspective, they never belonged in that psychiatric hospital. They didn't have mental health issues. They were there because they were distressed and they were having, behavioral challenges that were misinterpreted and so on. So clinical information that's chosen by the person and their family. And then back pages. One is called something like tips on how to work with me. Here are things that make me anxious that you should avoid. Here are ways to calm me down. And there people might choose to, include a recording of a comforting message that a family member is speaking to them. Or they might have a link to their favorite tune on YouTube or something, or on Spotify. There are also spaces in the app to upload videos or a picture to show, here's what I'm like when I'm at my best. See, I'm happy and athletic, right? It instantly humanizes the person for the clinician looking at the app. And then there are other resources in the back of that, things like tips on how to take a blood draw for me, or if you have to do an x-ray, here's the safest way to do it, that kind of thing. It's really quite customizable to what is most important for that person.
Mm-hmm. Yeah, so going in on that, Jason's connection, well, mainly focusing on U.S. stuff, how U.S. policy and culture and stuff. Some of this stuff is bigger than just the U.S. Is IEC mainly doing stuff in the U.S., or is there a way? Are there things that IEC is available or doing things outside the U.S. as well?
Um, it's a great question. So right now we're just focused on the U.S. because we're young. We're only 3 years old, and we want to feel really confident as we grow. But we have also, we do also have international partners in that they want to learn from us. We want to learn from them. It's just we haven't run programs internationally yet. So we have some partners in the UK. For example, they're also designing some apps, different ones, and they love the idea of embedding a link to their app in ours or vice versa. And there are researchers there who can bring a different country's perspective to help us understand what's going on here.
Thank you. I also see, I think you mentioned it earlier, but, somebody was talking about this, you talking about doctors being stubborn. Is there work going on in med schools or connecting to med schools to train people on, working with people with IDD? I know a lot of times in med schools, training around disabilities about 30 minutes, and it's usually the diagnostic box more than anything. Is some of that, is IEC part of that, or working with partners who are doing that?
Yeah, so first of all, we're relatively new to the field. So I want to give a shout out to organizations like the American Academy of Developmental Medicine and Dentistry, and a program called PATH, PWIDD, for persons with IDD. Both of those initiatives are really doing tremendous work training clinicians in training, whether those are medical students or nursing students or occupational therapy students. So we want to give a shout out to those folks. Our contribution to that is that we want to scale that, because initiatives like that are really grant dependent, and they happen in a certain number of schools, and then you try to expand. What we would like to do is go straight to the top to, for example, the Association of American Medical Colleges, and say, AAMC, can you work with us on a common set of competencies and a culture change campaign that we can push out through your platforms to all the medical schools in the country? And then their appetites will then be whetted to use the wonderful curricula that AADMD or PATH PWIDD have developed, or Special Olympics International. So that's how we view our job, is like, how do we scale the solutions that are there? And then sometimes it's true, Jason, there are still gaps, right? So one thing that helps with training is when it's not just one profession.
Yeah.
So it's already great if we can get all the med schools, but imagine if you had the same expectations across medicine and nursing and dentistry and physician associates.
Would that be because I know I was lucky enough to do LEND, which is Leader in Education and Neurodevelopmental Disabilities, which tends to be cross field. Is that sort of taking in some ways? Now that's an AUCD program, American University Centers Association. I always say American University Centers on Disability, so that's a specific thing. But that's like with, in specific state, there's specific LEND centers and stuff. Is some of that sort of that cross-sectional training and sort of teams or sorry if I cut you off.
Yeah, no. It's kind of complementary. It's not quite the same. What the Association of University Centers on Disability does is intensive training for interdisciplinary teams. What IEC is talking about is bringing together that Association of American Medical Colleges, but also the American Dental Educational Association, and the same for nurse practitioners, and the same for physician associates, and so on. Because when they can collaborate and come up with a common set of competencies to teach, it's more efficient for all of them. They can get it done faster. And it generates a lot of momentum, right? Because you don't want to be the profession that's left out. Right? You start to look kind of bad if all your peers are doing it and you're not. And we really like that peer pressure.
Yeah. Well, and I see there's a comment in the chat. Now, at Jason's Connection, we don't love to ask for funds. We don't want to make it that we are asking people. But one way to get involved is to be able to donate. Is there ways that people, big or small, can donate to IEC if they feel like that's what they want to do as one way to be involved? Because it sounds like there's multiple ways to be involved.
Absolutely. We so appreciate any donations. Again, you can go to our donate page at www.ie-care.org. And I think someone might put that direct link in the chat too. And there are lots of ways to donate, big or small. For us, it's the engagement and the relationship with you that counts. And again, as Jason says, just because you're a donor does not mean we wouldn't want to come after you to be a project partner too.
Thank you. What do you hope? What does is there things in 2024 that you all are looking forward to, or projects that are coming up, or things that you want to let people know as we're coming towards the end of the year for people to keep an eye out for?
Well, more straight A report cards from Yolanda, thing one.
Yeah.
There was a B plus in there.
All right. Yeah. Okay. This terrible thing she did with the B plus.
Oh my.
I think from our perspective, we're really looking forward to getting into the weeds in ERs in New York, seeing real clinical teams in emergency rooms use the app, make decisions based on it, learn from it, tell us what they learn. Same with the community members and making it better. We're really looking forward to having this first relationship with Delta Dental and working with dentists who are already welcoming of people with IDD as patients, because that's not always the case, and building resources to help them do that, right? So they can get basic training in how to support someone with communication challenges, but gosh, they might also really benefit from tools, some of which I mentioned before, like, can we create signs for them to print out and put at their registration desks? Can we give them, a short list of like inexpensive equipment to buy, assistive devices, or things like that to offer to patients with communication challenges? We really want to make solutions practical, and I can't wait for that, because there's been just a lot of planning to date on a couple of these projects, and now it gets real.
No, I appreciate it. And I see from Anna, we talked about ways to be on committees and boards and a little bit about donations, but are there ongoing volunteer needs, and how can people volunteer if they want to?
Sure. Same way, come to us through our contact page, and we will reach out and learn more about your interests and your skills. And your bandwidth, because we really don't want to tax our volunteers. And then we'll think about the best way to fit you in. There are lots of opportunities. We have worked with volunteers to do kind of like basic Googling kind of research for us, to look at medical literature for us, to do social media posting. We've had volunteers at some of our events. And sometimes, in other cases, people have tried to volunteer, but if they're a self-advocate, we're going to find a way to pay you unless you really make us not. So, sometimes we've done that for self-advocates to help us with plain language translation, for example, or Another great way to volunteer, frankly, is to share your stories with us. Stories fuel change.
Mm-hmm.
Your stories fuel change. We are just the engine. You are the fuel. And if you are willing to be generous in that way of sharing your lived experience, some of which may be really painful, and some of which may be really triumphant, all of that helps us to change hearts and minds in healthcare. And that is what it is all about. The technical stuff is not hard. It's the hearts and minds that are hard.
Yeah. I know that you just recently shared a story from Jensen that was really impactful. And I know there's been a couple others, and I can't remember everybody's name because I'm bad at names, but those are always so impactful. So I think we're getting towards the end. I don't know if there's any last thoughts that you all have or things that you've learned as you've done this that you would like to share, or, any last calls to action.
I just want to say what a privilege it's been to get to know you, Jason, and of course Yolanda, who has this. You guys haven't seen her in full form, but this lady has this amazing ability to make a room full of people laugh and cry at the same time. Like, you're laughing and the tears are flowing, and I think that it takes a really special intelligence to do that. And Jason, it's just been such a privilege for me to witness your contributions to our project work, and this very gentle wisdom and amazing analytic skill set that you have, where you can you can convince a PhD candidate that you know enough to stand toe-to-toe with them to get to better decisions on the ethics of how to apply artificial intelligence in healthcare work for people with IDD. I mean, I think that's astonishing. So I just want to say I had no idea what was going to happen when I took that leap of faith and started IEC. It took me a year and a half to make that decision. Had I known that these were the people I was going to bring into my life, I would have made the decision a lot faster.
Well, I appreciate it. I don't know, well, Yolanda, if you have any things that you would like to end on, and not to put you on the spot.
Yeah, no. I mean, just thank you for sharing your platform with us. Hopefully somebody saw a bit of themselves or their loved one's story in what we were talking about today, and realizing that, as horrible as it is, that these aren't, isolated incidences, and so many of us have experienced these things in medical settings. Also know that there are just as many people, if not more, working on changing that, and that the things that you've gone through, like Mai said, you'd be a fuel for change, and that in sharing your stories, not only are you, helping make the world a better place, it's also a very healing experience. So please know that you're not alone in what you've had to go through, and that you're still an amazing and valuable person. And there's so much that we as a community have given to the world and will continue to give. And just, happy holidays to everybody. Take care of the people around you. Never forget to say I love you, all those fun things. And just thank you so much for having us.
Yeah, thank you. I want to thank everybody who's watching for being participating, whether you're watching live or you're gonna watch or you're watching it asynchronous at a different time. I definitely want to thank you, Yolanda and Mai, for being part of this. I want to also thank the IEC team, Anna, Chris, Gretchen, Whelan, Malin, Anderson, Ray Pfeiffer, and Rachel Moore, and also to the Jason's Connection team, Susan Cutler and Jeff Harris, for putting this all together. It's been a lot of work and a lot of amazing collaboration, and I appreciate it all. Thank you to everybody for being a part of it.
Thank you.
Thank you.